All right, so let's take the next half of this lecture, which is talking about pharmacokinetics. So pharmacokinetics is the study of how does a drug enter, move around, get broken down, and leave the body. So from the term pharma, drug, kinetic, movement, this is really how we're thinking about not what does the drug do at the receptor. That's pharmacodynamics, and we'll start talking about that next week. But this is really the movement of the drug into, around, and out of the body. So this is usually referred to as absorption, distribution, metabolism, and excretion. When we talk about absorption of most psychiatric drugs, we're talking mostly about oral medications, although we are also talking about injected medications, both immediate acting and long acting. There's at least a couple of inhaled psychiatric medications, but mostly we're talking about oral medications. So with oral medications, the absorption can be affected by both the condition of the gut. So if the gut is inflamed, say with alcohol gastritis, that might make it difficult for drugs to be absorbed. If the gut is very short because of bypass surgery, gut bypass surgery, gastric bypass rather, then that could also make it more difficult for the drug to be absorbed. If the transit time is longer or shorter, so if a drug is moving more slowly because of constipation or more quickly because of diarrhea, we might see more or less absorption of that drug, respectively. Now, remember, going back to our anatomy class, so all the absorbed material from the gut is going to be first transported into the portal vein. The gut is lined by inputs for the portal vein. So all that blood is going to come back to the liver before it has a chance to go into the systemic circulation. Once it comes out of the liver, it's put into the inferior vena cava and gets pumped through the entire system. But before that happens, there's something called first pass metabolism, where the liver gets a chance to take usually a substantial portion of the active drug out. And this is something that was really evolved to reduce the effects of poisoning. So our evolved ancestors would have maybe eaten something that might make them sick. The liver has a chance to detoxify that before it gets pumped all around the system and potentially kills them. But this does create some challenges for pharmacology because the liver really bats first. So when we think about drugs being absorbed, in this case from the stomach into the portal vein, comes up into the liver and then out into the vena cava, this is known as the first pass effect or first pass metabolism, and it's typically measured in a percentage. So if a drug is 70% first pass metabolized, that means that 70% of the total absorbed amount of the drug is removed by the liver before it ever begins to circulate around the body. Once it is absorbed, it begins to bind to proteins. And so proteins are largely, albumin is the main one that's produced by the liver, and drugs will bind to that. And when they are bound to the plasma, they can't actually cross over the blood-brain barrier and to the receptor where they would have an effect. Now, they are dissociating or leaving these plasma proteins all the time. They're attaching and then detaching, but the amount that is bound to protein at any given time is not able to be biologically active. So this has relevance for patients that are experiencing liver impairment, because one of the impairments that happens with liver failure is an inability to make these plasma proteins. And so this is one reason why we might need to use a lower dose of a drug in a patient with liver problems, not only because would they have trouble metabolizing the drug at the same rate as somebody with a healthy liver, but they also would make fewer of these plasma proteins to bind the drug to. And then let's talk about the blood-brain barrier. So, often in psychiatry, we spend a lot of time talking about neurons because that is where a lot of our drugs have an effect. But it's also important to remember that there are other types of cells in the brain, and glial cells are the three types of cells which actually comprise a larger portion of the brain than neurons. And one of those types of glial cells are known as astrocytes. And you may have heard of astrocytes because maybe you've heard of glioblastomas or specifically an astrocytoma. Those are usually highly malignant forms of brain tumors. Well, astrocytes are these cells that really serve as sort of the pit crews for neurons. And one of the functions that they serve is they have these long appendages, kind of like starfish almost, that wrap around the blood vessels that are feeding the brain. And that is what actually comprises physically the blood-brain barrier. And these are lipid layers. So that means that drugs that pass through lipid layers easily, drugs that are known as lipophilic drugs, will pass out of the bloodstream and into the brain more quickly because they'll pass through that. Remember, likes like. So lipophilic drugs will cross through that more easily than a hydrophobic drug, or hydrophilic drug, something that's more water-based. Also, molecules that are too large or too highly charged also won't be able to get into the brain through the blood-brain barrier. So again, the blood-brain barrier is a clever, evolved adaptation to reduce the effects of poisoning, but it also makes some real challenges for pharmacology. And a place where this really matters would be, a good example would be benzodiazepines. So benzodiazepines, these are drugs used for anxiety, for sleep, for anesthesia, are all quite similar in what they do. Once they get to the receptor, the GABA receptor, they are positive allosteric modulators, which means they make GABA, the neurotransmitter, work more efficiently. And so they all do the same thing when they get to the receptor, but you'll notice that patients, and if you've tried them yourself, you'll know that some work more quickly than others. And one of the main reasons why that is the case is because of lipophilicity. So if you take a look at this chart here, alprazolam, diazepam, temazepam are all highly lipophilic drugs, which means they get out of the bloodstream barrier, across the blood-brain barrier, and get to work on those GABA receptors pretty quickly. So this is why these drugs tend to work more quickly. And in the case of something, say, like temazepam, which we typically prescribe for sleep, that's valuable because it tends to go to work fairly fast. So let's walk through the process of drug metabolism. So we've talked about absorption, we've talked about distribution and how drug rides around on albumin and is available only to get to its target if it's free from that albumin. Let's talk about what happens when it starts to be broken down. So in this case, we're referring to the drug as a substrate. And that substrate or that drug is going to go through one of two, sometimes both, of these metabolic pathways. So the first one is called cytochrome P450, or sometimes called CYP for short. And this is made up of different enzymes which have coded names that you're familiar with, like 2D6 or 3A4 or 2C19. There are several of them. And these are these do the job of breaking down the drug and making it more readily excreted, more water soluble, so it can be passed out in the urine. There's a parallel system known as gluconeryl transferases, sometimes referred to as GT or UGT, which do a similar kind of job. Now, there are some drugs that will go through a CYP 450 system first, and then the metabolite will go on to go through gluconeryl transferases. That's not always the case, but some drugs will go through one and not the other. Some go through both. We don't need to concern ourselves with those specific examples right now. But regardless, what comes out the other side is known as a metabolite. Now, metabolites can be active, meaning that they actually work on receptors, or they can be inactive, meaning they don't activate receptors. But either way, they're getting made more readily excreted in the urine, stool, or other forms of excretion, but largely urine. So mentioned, they come with these different names based on their genetic coding. And it's also important to note that these pathways are normally an average rate, just like most people are an average height. But there are some people that have very fast metabolic pathways, a specific one, say like 2D6. These would be referred to as rapid metabolizers. People who are rapid metabolizers will go through a drug more quickly than the average person, meaning they may need a higher dose for them to get a clinical effect. There can be slow metabolizers as well, and these are people for whom that same enzyme goes more slowly, which means the drug is going to come out more slowly, which means they may need a lower dose or they may get more side effects. And also things such as smoking can also influence the speed of these enzymes as well. There are some genetic groups that will be more likely to metabolize drugs more quickly or more slowly. And this is what pharmacogenomic testing is often looking at. And gluconeryl transferases do a similar function, which is to get that drug ready to be broken down, or they break it down, so ready to have excreted as in the urine. So let's walk through an example of this. So cytochrome P450 2D6 is the enzyme that is responsible for breaking down the drug venlafaxine. So in this case, the substrate is venlafaxine. It's going through the CYP2D6 enzyme. Okay, out comes the other side is O-desmethyl-venlafaxine. O-desmethyl-venlafaxine is sold actually as the drug Pristiq. So it is an active metabolite of venlafaxine, and then that is excreted out in the urine. Let's take another example and look at how these interactions play out. So when we talk about drug-drug interactions, this is what we're talking about. So in this case, let's take the example of a drug called hydrocodone or Vicodin. Probably familiar with this drug. It's a common painkiller. Now, hydrocodone is interesting because it is what's known as a prodrug. It is actually not active in its hydrocodone state. It needs to go through cytochrome P450 2D6 and be converted into hydromorphone, also known as Dilaudid. And that's actually what provides the pain relief. The hydrocodone is a prodrug. Hydromorphone is the active drug that provides pain relief. Now, let's take a look at how this interacts with another drug, something called venlafaxine. So venlafaxine, as I mentioned before, is a fexor. It is, in addition to being a substrate of 2D6, it is also an inhibitor of 2D6, which means it, when introduced to a system, will slow down the 2D6 pathway. So let's think about this patient who is taking hydrocodone, let's say on an ongoing basis for some kind of pain condition, and we throw in venlafaxine, an inhibitor of 2D6 in that system. So now that that pathway is going more slowly, that conversion of hydrocodone to hydromorphone is slower, and the clinical outcome is decreased pain relief. So this is a clinically relevant drug-drug interaction caused by the inhibition of 2D6 by venlafaxine. This can also happen in the UGT system, in the gluconeryl transferases. So let's take an example of a drug, a substrate, known as lamotrigine or Lamictal, commonly used for the treatment of depression and bipolar disorder, also for the treatment of epilepsy and seizures. So that goes through the gluconeryl transferases. Now, if we introduce a drug known as Tegretol or carbamazepine, this is an inducer. It speeds up the rate at which gluconeryl transferases process drugs. So the patient is already taking lamotrigine, and then we throw in carbamazepine. That's going to cause those gluconeryl transferases to go even faster than usual. What's going to happen then? Lamotrigine will be chewed up at a faster rate, which is going to cause possibly the depression to return or possibly seizures to return. So in order to prevent that, we would need to double the dose of the lamotrigine in order to maintain the same blood levels when we add the inducer of those gluconeryl transferases, carbamazepine. So that's the bottom line in there, is that you would have to increase the dose of the lamotrigine in order to maintain the same blood levels and presumably the same clinical effect. Here's another example. So gluconeryl transferases are also responsible for excreting the hormones in oral contraceptive pills. So they're coming out through the gluconeryl transferases, getting ready to be excreted, and we add that same drug, carbamazepine, in there, remembering that it's an inducer. It's going to speed that process up, and out is going to come the birth control pills, and they're going to become less effective. So the bottom line here is that if you have a patient who is taking oral contraceptives, we introduce an inducer like carbamazepine, we need to advise that patient to use backup contraception. Another common term in pharmacokinetics is known as area under the curve. And you can think of this as the amount of exposure that the body has to a drug over time. And as you can see, the route of administration creates the shape of the area under the curve. So IV, which is this sharp drop off on the right, you see all the drug is introduced right away. So in an IV push, all the drug comes into the body all at once, and then it begins to be metabolized and excreted. With oral medication, there's this period of time on the left of that peak, which is the time at which the drug is being absorbed from the gut into the bloodstream. And so there's a time to peak sometime after the drug is ingested, and then it begins to be metabolized and leaves the body. Some key terms to pay attention to here. Just to point out some things here, so we've got the concentration maximum, or Cmax, which is that that amount of drug at peak. The amount of time it takes to get there is known as Tmax. The drug begins to be felt effective when it crosses over this minimal effective concentration line. So this area between the maximal concentration, therapeutic concentration, and the minimal effective concentration is known as the therapeutic window or therapeutic range. Typically, when the drug levels drop below the minimal effective concentration, as they are right here in the middle of the chart, you begin to lose the effects of the drug. So let's take an example of that introduces the idea of half-life. So half-life is the amount of time it takes for the amount of drug in the body to be reduced by 50%. So in this case, we'll make a very clean example. We'll say a drug with a 12-hour half-life that has a 100 milligram dose that is 100% absorbed and has no first pass metabolism, which would be a very uncommon drug, but we'll run with it for purposes of this example. So you'll see at maximum absorption, you're going to have 100 milligrams in the bloodstream. One half-life later, or 12 hours later, so you're going to then have 50 milligrams left in the body. Another 12 hours later, you'll have half of that, so 25 milligrams. Another 12 hours after that, 12.5 milligrams, and so on. It typically takes about 5 half-lives for a drug to reach what is known as steady state. So what steady state is you can see in this red section of the graph, each time the drug is taken, it hits a peak, it starts to be eliminated from the body, and then we take another dose. So it goes up a little higher, and it goes down again, and it goes a little, and then we take another, it goes up. It begins to go down again. But you'll notice over time, that level begins to kind of flatten out. We kind of hit cruising altitude, if you will. There's still a day-to-day peak and trough. So the peak is typically a few hours after the drug is taken, and the trough is always right before the drug is taken next. So this is relevant to blood levels in psychiatry for certain drugs, such as lithium and valproate, which are dosed based on blood levels. And we take those blood levels, they're typically standardized to be measured at the lowest point of the drug cycle, so at the trough. So taken, typically, the blood level would be drawn right before the next dose is taken. It's also important to understand that some drugs, not all, but will break down into active metabolites. And some of those active metabolites have been turned into commercial drugs. So for the example here, diazepam or Valium is broken into nordiazepam and temazepam. Nordiazepam and temazepam both break down into oxazepam. And you might be thinking, oh, I've heard of temazepam. That's a sleeping medication. You'd be right. There's nothing special about it that makes it a sleeping medication other than it's pretty lipophilic and has just about the right amount of half-life to keep you asleep for the course of the night. And oxazepam, which is known as Serax, a kind of a lesser known benzodiazepine. But the point here is that somebody who's taking diazepam could do a tox screen and show positive for diazepam, temazepam, and oxazepam. And that wouldn't mean that they're taking 3 different benzodiazepines. It would mean that they are showing the active metabolites from diazepam. And another one that I mentioned before was venlafaxine, which converts into desvenlafaxine, which is the active metabolite, which has antidepressant effects and is sold as the drug Pristiq. So then finally, elimination. Now, some of the drug is just not going to get absorbed and it's just going to go out into the stool in the same form it came in. So not converted, not absorbed. The rest is going to be metabolized, converted into a more water-soluble form, and made so that it can be excreted largely in the urine. And this is why renal function matters, because if the person can't eliminate the drug, then it's going to stick around in the body. And so this is why we often use lower doses in people with renal issues, in addition to people with hepatic issues. So let's wrap this up by going on an adventure through a dose of one of Dr. House's fictional medications. We'll call it Forget It All. So here he is at the end of the day. It's 6 p.m. and he's taking his dose of Forget It All. And here's what we know about this drug. A standard dose is 1,000 milligrams taken twice a day, BID. It's 50% absorbed in the gut. It's 70% removed in first pass metabolism. It's bound 90% protein bound. It's highly lipophilic. It has an onset of 1 hour and a 3 hour time to peak. It's metabolized by CYP2D6. It has a 3 hour elimination half-life. And its target is the IDRC-DU receptor in the brain, which is not a real thing. So let's see what happens when he takes it. He swallows that 1,000 milligrams of Forget It All, remembering that 50% is absorbed. So that's going to go into the portal vein and go into the liver. The other 50% is just going to pass on through and come out in his poop unchanged. So we've got 50% has entered the body, 50% is just going to pass on through. First pass metabolism of this drug is 70%. So after it's going through the stomach and it's being absorbed into the portal vein, which then goes up into the liver and then through the liver comes out into the systemic circulation of the inferior vena cava. So 70% of this drug is taken out by first pass metabolism. So that means 500 milligram goes in and 70% is removed, which means there's only 150 milligrams entering into the systemic circulation of that 1,000 milligrams that he began with, because 50% went out in the stool, 50% got absorbed, 70% got removed. So we're now down to 150 milligrams of that 1,000 milligrams. Now let's take a look at plasma binding, protein binding. So remember, it's 90% protein bound, which means that only 15 milligrams of that 1,000 milligrams that he took will actually be floating around free in the bloodstream, able to cross over the blood-brain barrier and go to those receptors on the other outside of the bloodstream. And it's only that free Forget It All that once it is released by the proteins, so there it is attaching the proteins, and here it is moving on, crossing the blood-brain barrier, getting to those receptors. It's only that percentage that is free floating, so 15 milligrams, that can actually do that. Now remember, there's always, it's not bound forever to plasma. It's sort of docking there and then it's releasing. It's just sort of a drive-by situation. But at any given time, 90% of the drug is attached to plasma proteins, which means only that 10% that's free can cross the blood-brain barrier and hit those receptors on the other side. And now that metabolism continues to happen even after the first pass. Of course, every time the heart pumps blood through the liver, those CYP2D6 enzymes have another crack at it, okay? And they keep converting it into Forget It All, which is then able to be excreted through the kidneys and the urine. So let's track this over time on this chart here. So there it is, end of the day, 1,800 hours. He takes his dose, okay? And 3 hours later, we get to Cmax. We get to 150 milligrams that's in his bloodstream. It took 3 hours to get there. That's Tmax. And he started feeling it after about an hour, because that's when it starts to cross over the minimal effective concentration. And it continues to climb until it hits that 3 hour mark there, where he's got 150 milligrams. Now, elimination half-life is 3 hours also. So that means at about midnight, he's down to 75 milligrams. At 3 in the morning, he's down to about 37.5 milligrams in his bloodstream. And at 6 a.m., he's down to 18.7 milligrams. So, and then he goes to pee, and out it comes. So when would we expect him to no longer begin to feel the effects of forget it all? We'd say it's right about here, right about 3 a.m. Between 3 and 6 a.m. is when the effects would start to wane because he's now gone below the minimal effective concentration. So this is typically why a BID dose would be taken again here, which would cause this level to go up again. And this sort of up and down is what happens when we take drugs on a regular basis. Now, we can kind of get a sense of how long a half-life of a drug is by how often we have to take it. So a drug that is taken multiple times a day typically has a very short half-life. A drug that is only taken once a day, such as something like fluoxetine, has a very long half-life. And so that drug takes a long time to come out of your system. So for your work this week, one of the things I want you to take a look at is go to the PI or prescribing information for a drug. And I would suggest using a drug that's come out maybe in the last 10 to 12 years or so, because really the FDA in the last decade or so has required drug manufacturers to have a lot more data to present here. Now, this is not the same as Lexicomp or Hippocrates. I actually want you to go to this FDA website here and find a drug. So this is the labeled information when we talked about in the first half of the lecture, the drug label. This is all this sort of data free to anybody who wants to look it up. And you go ahead and skip ahead to section 12, which will tell you about pharmacokinetics and pharmacodynamics. And you're going to report that back on one of your assignments this week. So we've mostly talked about pharmacokinetics this week, which is the drug moving around the body. And next time we're going to talk about pharmacodynamics, which is what the drug does in the brain. And that's typically where we want our drugs to work, but usually side effects are caused by hitting receptors that in places where we don't necessarily want it to hit. And we'll talk about both of those when we meet again. So thanks again for your attention. If this has been a little challenging, please encourage you to go back over, listen to this lecture maybe again. And what you'll find is you'll start seeing these things connect together, if not today, over the course of the next few weeks and hopefully the next few months. And hopefully for the rest of your career, your knowledge will continue to deepen and this material becomes even more rich and interesting the more you understand it. So stick with it. It's challenging, but I think you're going to start putting the pieces together as you go through this process. Let me know if you have any questions. Thanks for your attention. Bye.